we're going to get started in just a few minutes here. We're just going to give everybody 2 more minutes and then we'll get started. Hello, everyone. We're going to go ahead and get started. I just want to welcome everyone to today's webinar entitled Recent Trends in Federal Health Policy, an Update for Advocates. I'm Stacey Worthy. I'm counsel to AIMED Alliance.
And I'm John Wylam. I'm the staff attorney at AIMED Alliance.
Before we get started, I just want to note that you can submit text questions to our speakers throughout the webinar. You can type your questions into the questions pane of the control panel, which is located on the top right of your screen at any time. We'll then answer those questions during the Q&A at the end. Let's get started.
All right, so about us. We are AIMED Alliance, and we are a 501c3 nonprofit organization that seeks to protect and enhance the rights of healthcare consumers and providers. We're a team of attorneys, and we provide legal analysis, public education, and awareness to foster understanding and engagement on health issues.
To give a quick preview of our discussion today, we're going to be discussing the rising cost of care and calls for cost savings, recent budget request, a recent case that could invalidate the Affordable Care Act, the Office of Attorney General's rebate proposal, the impending Medicare Part B cliff, the Center for Medicare and Medicaid Innovation's International Pricing Index Demonstration Project, a CMS rule that would implement Copay accumulator programs and non-medical switching, a recent rule that would expand telehealth, a rule that would allow step therapy and would weaken Medicare Part B protected classes, and then we'll end with a Q&A. So we're going to just take a really quick poll right now. Launch the poll question.
All right, and this is just asking which of the following do you represent, and you can put multiple answers for this.
You can go ahead and select. Give it another 30 seconds. Okay, let's manage this poll. Is that showing? Oops. There we go. Sorry, a little technical difficulty there. We will share those results. So we can see that most of you guys are patient advocates, which is great. But we do have a good mix of everybody, which we also like to see. So let's get started with this presentation. So I just want to start by talking about the rising cost of healthcare. The current administration has made it a top priority to reduce the cost of care. And in response to this, federal agencies such as it's no surprise to anybody that healthcare costs are rising. So there was a recent CMS report in 2017 on healthcare spending, and it showed that we spend approximately $3.5 trillion on healthcare. That's approximately $10K per person. Healthcare spending increased by 3.9%, and that accounts for about 17% of the nation's GDP. Biggest expenses include hospital care, physician and clinical services, and prescription drug costs. You can see from these headlines, this really does impact families. So we see that more families are going to GoFundMe to pay for their medical bills, and people are dipping into their retirement funds. Now, as I was saying, the current administration has made this reducing cost a priority. And several agencies have responded by introducing rules, policies, and proposals that could reduce healthcare costs. While some of them may achieve these intended goals, others could also reduce access to quality care and increase costs for many Americans. So the first one we want to go over is the President's 2020 budget request. Now, this was very recently released. It was on March 11th that the administration released this request, and it's for fiscal year 2020. So what is the President's budget? Well, it's a symbolic document that communicates the administration's priorities to Congress and it requests specific funding levels for government programs. So it contains policy priorities, but it's not binding. Ultimately, Congress holds the authority to determine whether that government funding is going to be spent and at what level. There are several pros and cons to this budget request. First, it calls for a spending cap on catastrophic coverage, the catastrophic coverage phase of Medicare Part B plans. We're going to hear about the Part D cliff later on in the presentation, but suffice it to say that Medicare beneficiaries have significant out-of-pocket costs leading up to what is called the catastrophic coverage phase of their plan. This proposal would cap those costs, thereby providing beneficiaries with cost savings. It also called to eliminate cost sharing for generic medications. Again, that reduces out-of-pocket costs. And then it calls for increased payments for primary care providers. Currently, we have a shortage of primary care providers, so these increased payments could incentivize people to enter into primary care medicine, or at the very least, encourage current providers to treat more Medicare beneficiaries, whereas otherwise they may have opted out of the program. It also calls to streamline the appeals process for Medicaid. This is really vague on what this would entail, but ideally, a streamlined appeals process would, when an individual is denied care or service or treatment, they would appeal, and the process would be very simple. They would use uniform applications. They'd have short deadlines for response. Materials would be submitted electronically, and individuals who are going through that appeals process would be able to continue their benefits while that appeal is being processed. The proposal also would call for, does call for curtailing surprise out-of-network medical bills. So this is a common problem we see when out-of-network providers are practicing in in-network hospitals. So typically the proposals that would reform this type of behavior call for increase in transparency around pricing, requiring notice about whether the provider is out of network prior to administering the services, and ending balance billing, which is when the patient is billed the difference between that in-network and out-of-network rate. And then additionally, oh, we're still not seeing the slides? I'm sorry about that. Let's fix that. Hide. Okay. So the last pro on our list is that it would call for greater transparency, and that would be transparency likely of pricing and of benefits offered. So there are quite a few cons with this budget request as well, and that includes excluding the value of manufacturer discounts when patients are in Medicare Part D coverage gap. Again, we're going to go over that in a lot more detail later, but currently Medicare beneficiaries in the coverage gap, which is also known as the donut hole, are required to pay over $5,000 out of pocket in coinsurance for their medications before they reach the catastrophic phase of their health plan. Manufacturers may provide discounts for medications. However, these discounts would not count towards that threshold, meaning beneficiaries would remain in that donut hole for a longer period of time. This is essentially what's known as a Copay accumulator program, or somewhat equivalent to, I shouldn't say it is, it's very equivalent to. Additionally, this budget proposes that state Medicaid programs use closed formularies, which mean that excludes medications from coverage, or that could exclude medications from coverage that have historically been required for coverage. Additionally, the proposal calls for greater cost-sharing requirements for Medicaid enrollees. Now, this is a vulnerable patient population that often lacks disposable income, so that could result in reduced access to care. And then the proposal also asks for mandatory work requirements. There are currently some lawsuits that address this issue and whether Medicaid was intended as a pathway to work program or a social safety net. The current mandatory work requirements that have been passed in some states, such as Arkansas, are pretty burdensome processes with time-consuming paperwork. So based on what we're seeing in Arkansas, over 18,000 residents lost Medicaid eligibility for failure to comply with those mandatory work requirements. So this really could result in reduced access to care. And in general, the proposal calls for a reduction of Medicare spending or funding by an estimated $800 billion over the next 10 years, which could reduce the growth of various provider payments. So what can you do? Well, there is no official comment process for the budget request. However, you can still send letters. So if you want, you can send letters to the White House or to Secretary Azar or CMS Administrator Verma. Next, I want to go over Texas v. United States. So this is a recent case impacting the validity of the ACA in its entirety. Last year, 20 state attorneys general argued that the individual mandate was unconstitutional. So they put forth this case in Texas. They argued that when the tax reform bill was passed last year and it zeroed out that individual mandate tax, the provision no longer raised revenues. It's no longer, the ACA mandate is no longer a tax. And as a result, the entire ACA should be struck down because it's unconstitutional. Because prior case law said that the only reason the ACA was constitutional was because it was pursuant to Congress's taxing ability. Here, the defendant was the DOJ. Originally, the DOJ refused to defend against most of the claims, but did argue that only the individual mandate and the pre-existing condition protections should be struck down, and the remainder of the ACA should remain in place because it's severable. The court sided with the defendants in December 2018, and the parties have since appealed. The current appeal is taking place in the Fifth Circuit. Intervening attorneys general recently filed their brief defending the Affordable Care Act and arguing that even if the individual mandate is unconstitutional, the remainder of the ACA should remain intact because that was Congress's intent when it passed the tax reform bill. It did not intend to revoke the ACA in its entirety. Yesterday, the DOJ reversed its position and agreed with the Texas judge in that judge's opinion in its entirety, that the entire ACA should be invalidated. So basically, it's trying to do what Congress could not do. In this case, if you want to take action, I say stay tuned and see how it plays out, or you could file an amicus brief if you want. Basically, as a health insurance consumer, anybody has standing. So that is a possibility. Moving on to rebates.
All right, so let's talk a little bit about rebates now. And first, what are rebates? Rebates are a back-end financial mechanism that is used between pharmaceutical manufacturers and middlemen or insurance plans that they use to compete with each other to get favorable formulary placement for their products. So in that context, we're talking about a proposed rule that was just issued by the HHS Office of the Inspector General last month in February 2019. So this is a proposal that impacts only Medicare Part D. However, it has some pretty significant changes to the anti-kickback statute. So the anti-kickback statute is a criminal statute that prohibits payments that are used in exchange for patient referrals for an item or service that's payable by any federal health program. So to give you an example, it would be a federal crime for you to pay a doctor to refer their patients to you if the services that you provide for those patients are reimbursed by Medicare. So there are certain safe harbors within the anti-kickback statute. And one of those safe harbors protects rebating arrangements between pharmaceutical manufacturers and those middlemen. And so ordinarily, that would run afoul of the anti-kickback statute, but they are protected by this safe harbor. So back to the proposal last month, HHS OIG decided that they want to eliminate the existing safe harbor that protects rebates in Medicare Part D, and they want to instead create a new safe harbor that will protect discounts that are given to consumers at the point of sale. So instead of having this back-end rebating arrangement that patients don't really see and maybe or maybe don't benefit from, patients will instead be seeing a discount on the prescriptions that they fill at a pharmacy. Or at least that's what HHS OIG intends by putting this proposal out there. So the reason that rebates can be a little bit problematic is because people often point to them as an incentive that pharmaceutical manufacturers have to continue increasing their list prices. So if we play this out a little bit, a manufacturer can offer a larger and larger rebate to the middleman for favorable formulary placement, and that rebate can be even larger if the list price for the product is higher. So that gives manufacturers a reason to keep escalating list prices so that the rebates they provide will be greater. So we're talking here about reforming this system because it contains some perverse incentives and it doesn't really benefit patients, or if it does, patients don't really see it and they don't really understand it. So I want to point out here that one interesting part about rebates is that they go against the original purpose of what health insurance is designed to do and who it's for. So with insurance, the way we use it today, we have risk pools that are set up with healthy people that can balance out the costs for the less healthy enrollees. And when you have the rebate arrangements as they work now, you effectively have the sick enrollees filling prescriptions for expensive medications, and those rebate dollars are flowing into the health plan, and the health plan is using those dollars to reduce premiums for all enrollees. So in a way, you have the sick enrollees subsidizing the costs for the healthy enrollees, which is kind of the opposite of how things should be working. So this proposal would reverse that and allow patients to benefit from these rebates. And that will no longer mean that those dollars are being used to lower premiums for everybody else. So this was just issued last month, and the comment period is open until April 8th, 2019. We will be generally supporting this rule. We're still developing what our response is going to be, but I can share some of those details with you today. Like I said, we're generally supporting this rule, but we're urging a thoughtful and balanced approach. We really want to make sure that this proposal is fully thought out and that there aren't any nasty unintended consequences that could impact adjacent markets. Like I said, this is limited to Medicare Part B, but federal health policy is very interconnected, so it's possible that changes you make to Medicare Part D could have impacts in other federal health programs or even private plans. We are going to be pointing out that the HHS OIG is really hoping that the supply chain actors are going to stop engaging in the behavior that was protected by the old safe harbor and instead engage in the behavior that's protected by the new one. Now, you would think that is an easy assumption to make, but there is no guarantee that those actors are going to do what HHS OIG thinks they're going to do. So that carries with it the risk that instead of having rebates as they work today, we could have no rebates, which means that health premiums are not getting reduced by them. And on top of that, they're also not getting used for point-of-sale discounts. So patients filling prescription medications that are rather expensive are also not benefiting from them. So it's a very real possibility that this could backfire, not work the way it was intended, and drive up costs for everybody. And that's something that we want to avoid. There is the lurking issue of a series of lawsuits from the 90s that were federal antitrust lawsuits that were consolidated into a single action. And this is something that led to the rebates as we know them today. Before this series of cases, the manufacturers were offering upfront discounts to different actors in the supply chain, and they got in trouble for that because that runs afoul of the antitrust law, which prohibits actors from engaging in price discrimination. So when you have coupons up front, it would have been illegal for them to offer one coupon for one value to one person and a coupon for a different value to a different person. So after this lawsuit, all those manufacturers entered into a settlement saying that they were no longer going to engage in that. So now we have rebates as they work today. And it looks like we're going to be going back to the way things were before, but that settlement still exists. And I think that manufacturers could still be wary of possible consequences of using these upfront discounts instead of rebates. So that's something that we're keeping an eye out for. And the last thing that I'll say on this is that recently we've been able to move towards value-based contracts where we can pay for the value that is delivered, but required as part of that is an after-the-fact mechanism where that value can be determined, and we can then decide what was the value for that and what's going to get paid for it. So that's a very similar thing to the way rebates work today, and this proposed rule could threaten the progress that we've made towards value-based contracting, which in some cases can save money, so we want to be cautious about that.
Great. So moving on to Medicare Part D, we want to talk a little bit about the cliff. So in 2020, Medicare beneficiaries could face a $1,250 spike in out-of-pocket costs, which is referred to as the Part D cliff. Just to give you a little bit of background about Part D plans, there are four stages of coverage. The first is the deductible phase, when beneficiaries pay monthly premiums and 100% of the medication costs until they hit their deductible. And then the deductible does vary from plan to plan, but it can't be any higher than the $415 in 2019. Next is the initial coverage phase, in which the beneficiary pays a copay or a 25% co-insurance until the initial coverage limit is met, and that's about $2,800. They then enter into the coverage gap, which is also known as the donut hole, and at that point they have to pay a 25% co-insurance for brand medications and a 37% co-insurance for generic medications until they reach a threshold of just over $5,000 in 2019. At that point, once they get to that $5,000 threshold, they reach the catastrophic phase and pay a small copay or a 5% coinsurance. The threshold for 2020 is to get to that catastrophic coverage phase is jumping up to $6,350, meaning beneficiaries will be staying in their donut hole even longer, and they could be paying hundreds of dollars per month out of pocket. That could delay, or that could result in delays or foregoing needed treatment altogether. And in fact, there was a recent study that showed that the likelihood of abandoning a medication increases fourfold when cost sharing is greater than $500 in that Medicare Part D plan. So how to fix this? We recommend, the only option to fixing this really is federal legislation. Ideally, that legislation would include enacting a cap on out-of-pocket costs for Part D. That would be similar to the Medicare Advantage plan's cap, which is about $6,700 for all in-network services and $10,000 for out-of-network services. But plans can set it lower, and that includes services throughout the entire plan, so regardless of whatever phase that you're in. And the second recommendation would be to remove cost-sharing requirements for Part D beneficiaries who reach that catastrophic coverage phase because they've already paid so much out of pocket. The COB, Congressional Budget Office, conducted a study that projected that adding out-of-pocket cost caps and increasing health plans cost sharing for catastrophic coverage as opposed to cost sharing for beneficiaries would save the federal government $1.5 billion over the next 10 years. So moving on again, we're going to talk now about the International Pricing Index.
All right. Sorry, we've got a little bit of noise in here right now. It's passing. So this is a demonstration program that was set forth by the Centers for Medicare and Medicaid Innovation, or CMMI. That's a part of CMS that sets forth demonstration programs like this to test new and experimental ways to deliver care or pay for it, hopefully to improve care and save money. So this is a demonstration program that impacts Medicare Part B. And Medicare Part B is often used for patients who need to get a medication administered by a physician. So that often involves them going to see a provider and getting that administration in person. So this demonstration would dramatically shift how medications are acquired and paid for in that program, and it would be mandatory for roughly half of the providers that participate in Medicare Part B. So talking about how it dramatically shifts how medications are acquired, currently providers use what's called buy and bill, where they are themselves responsible for acquiring the medication and administering it to the patient, and afterwards they can seek reimbursement from CMS. And the reimbursement amount is the average sales price of that medication plus a percentage add-on. It's a percentage of the average sales price. So the administration is concerned that that add-on percentage does give prescribers an incentive to prescribe more expensive medications to their patients, because that would mean that they would get paid more at the end of the day for that administration. So in place of this, the administration wants to insert another middleman into all of this, and they would require providers to use what's called a vendor. And that vendor would be responsible for obtaining the medication from the manufacturer, as well as negotiating over the price of that medication, shipping that medication to the provider, and then seeking reimbursement from CMS. So it takes a lot out of the hands of providers, which in some ways could free up their time for other things, but also it kind of limits their interface with how drugs are acquired and paid for, and it just adds an extra layer of administrative inefficiency that some providers might like, some providers might not like. So the vendors will be paid what's known as the target price, and the target price is calculated based off of a number of reference countries that will be used. They'll be looking at the prices that are available for a specific medication in those countries, and the price in the US will be based off of that price. So what I want to point out about that is that it's really an apples to oranges comparison, because we have a very, very unique healthcare system in the United States, and a lot of the reference countries that they'll be using have single-payer healthcare systems, where the government has much stronger negotiating leverage to get more price concessions out of manufacturers. And so comparing those two things just doesn't really line up really well, and trying to just use the prices that they use, it's not really going to be as simple as that. So we're concerned that by doing that, it's going to be importing access delays. And by that, I mean that there is commonly a 4-year delay in when a medication launches and is available in the United States, and when it's available in countries like the reference countries that have single-payer healthcare programs. So we're concerned about how that could impact access, and we're also concerned about just technically how this could all work. We're concerned that things could just not work out the way they're intended. The vendor program, maybe they don't get as many people participate as vendors as they had imagined. I want to point out that this is very similar to the competitive acquisition program that was demoed from 2006 to 2008, and there were a lot of structural similarities between these two programs, and that program had to be shut down because they didn't have enough providers and vendors participating, and there were too many adverse events. And so they decided the best thing to do was to shut that down, but now it looks like they're trying that approach again. Maybe things will be a little bit different, but it's kind of hard to tell at this point. So the comment period for this initial advance notice of proposed rulemaking has closed. It closed in December of last year, but CMS did indicate that they are looking to release another proposed rule in the spring of 2019. So we're all expecting that to come out any day now, but I also do want to point out that it's possible that they've backed off this idea and they are no longer interested in pursuing it. We haven't really seen an indication one way or another, but I will mention that in 2016, I believe, when the Obama administration was looking at their Part B demonstration program, they approached it in a very similar way, and it wasn't until the Trump administration took office that we learned that the demonstration had been scrapped and was no longer being worked on. So there's a few things in our comment that we want to just bring attention to. And one of those has to do with just CMMI itself. CMMI was created by the ACA, and as Stacy mentioned earlier, the ACA is currently being challenged in court, and if the ACA is repealed or replaced or declared unconstitutional and invalidated, or some combination of all of the above, CMMI would no longer exist, and they would no longer have the authority to launch this demonstration. So we think that it's not really wise to want to launch a 5-year demonstration program that's so enormous like this in the face of that kind of uncertainty. So we really want CMS to go back to the drawing board with this and tailor things a little bit differently to ensure that the program can work the way it's intended, and that in doing so, it's going to actually reduce costs for enrollees.
So next, we want to talk about the Notice of Benefit and Payment Parameters. This was introduced in January 2019 by CMS, and it applies to individual and small group marketplace exchange plans, also sometimes referred to as Obamacare plans or healthcare.gov plans. CMS would allow these exchange plans to make mid-year formulary changes in which plans could add new generic medications to the formulary, which is wonderful. We always want more options. However, these plans would also be permitted to remove equivalent brand medications or move those medications to higher tiers. In most instances, this likely won't be a problem because there are typically no meaningful differences between most brand and generic medications. However, it may be an issue for certain medications or for individual patients in some cases. And for that reason, it's very important that these individuals have a pathway to request an exemption. However, under this proposal, they can only request that exemption if the medication is excluded from the formulary, but not if it's moved to a higher tier. And in some cases, when that medication is moved, they're not going to be able to afford it anymore. So we submitted a comment, and we argued that CMS should not allow negative mid-year changes, that these changes are inconsistent with the Affordable Care Act's guaranteed renewability provision, which only allows a change at the time of coverage renewal and no other time. So essentially, when you're in that open enrollment phase, when the plan is selecting their benefits for the year, that's when they can make the changes. But once you're locked in, the plan's benefits are supposed to stay as is. Also, this rule could result in non-medical switching in instances where the brand is necessary. And non-medical switching refers to cases in which a cost-driven formulary change results in a stable patient not being able to afford his or her medication and needing to switch to something else. Non-medical switching can have a negative physical impact, including disease progression or relapse. There was a recent study by the Indiana Stable Patient Protection Coalition that reported out some of the bad side effects of switching. It is important to note that this study was not necessarily of switches between brand and generic, but it's still illustrative of some of the things that can occur when a stable patient is switched. And that included that 56% of respondents reported side effects from the new medication, and 92% reported that side effects were worse than the initial medication. Again, I just want to point out here that the exemption process can be burdensome, so even if that is an option for people, there's no guarantee that they'll still get access to their treatment. So that's why we really want some kind of reform here. This notice also implements basically what our Copay accumulator program. So it prohibits Copay assistance from counting towards the patient's maximum out-of-pocket limit if both a brand and generic medication are available. So when a patient gets copay assistance or a coupon from a drug manufacturer, that's what doesn't count towards the deductible or that out-of-pocket limit. It's essentially a double dip in which the insurer is receiving the full amount of the deductible based on that coupon, but then also extending how long it takes for that patient to spend down that deductible. If you think about the way coupons currently work, when you go to a grocery store and you hand a $1 coupon for milk to the cashier, you get that value. The grocery store doesn't get it. But here, this is equivalent to the grocery store keeping that value. So this is especially a problem for patients who are in high deductible health plans, which have grown in popularity over the past few years. So more than 21 million Americans enrolled in high deductible health plans in 2017, and that was a 9.2% increase from 2016. So once assistance runs out and the medications become unaffordable, they have that high deductible, and so if they can't afford their medication, there could be a lack of adherence, switching, or abruptly stopping treatment altogether. Additionally, these copay accumulator programs typically use very confusing language if they're disclosed at all. So we've seen plans use terms like copay card benefit, out-of-pocket protection, benefit plan protection, all of which can convey a benefit to the consumer rather than a detriment. And we need to allow for some sort of exemption here to really protect these patients. Additionally, we need to offer adequate notice so that patients don't select high deductible health plans if they need a brand medication that they might not otherwise be able to afford once their copay assistance doesn't count. One other thing that this notice proposed was a change in cost sharing. So it prohibits, so if you take a brand medication and you fill that medication, you would pay your co-insurance or co-payment for the brand medication. However, only the amount that you would have paid for a generic equivalent will count towards that annual out-of-pocket limit. So basically, you are paying, but you're not getting credit for what you are paying out of your own pocket. We suggest that CMS scrap this proposal altogether because it's inherently unfair and inconsistent with the definition of cost sharing to take a beneficiary's money and then not count it towards that cost-sharing requirement. Also, this proposal did not allow for an exemption where a brand medication may be medically necessary. So here too, the comment period has closed, but that doesn't mean that if you feel strongly about this issue that you can't write to CMS and Congress. We do encourage you to do that if you do want to comment on this. Next, we'll be talking about telehealth.
All right, so this one is a little bit simpler than some of the others we just got finished talking about, but telehealth and Medicare Advantage. So in October of 2018, CMS released their contract year 2020 Medicare Advantage and Part D proposed rule, and they are using this proposed rule to promote flexibility and innovation among those plans. So the one provision of that rule we'll be talking about today relates to telehealth, and in this, CMS wants to allow Medicare Advantage plans to incorporate telehealth benefits into their standard benefit package. So that's something that was originally written into law in the Bipartisan Budget Act of 2018, and this regulation merely implements that. So what this actually changes is that the way things work right now, Medicare Advantage plans are able to offer telehealth benefits in their benefits package, but they currently have to be financed with other dollars, through higher premiums from enrollees or rebates they're able to extract from the supply chain or something like that. And so what that means is that they're often at a disadvantage if they decide to implement those benefits in their package, because a consumer will look at that plan and say, well, they're more expensive. I don't know what I'm really getting more out of that. I'm going to select this other cheaper plan. So with this change, Medicare Advantage plans will be able to more efficiently compete with each other because they'll be able to incorporate those benefits into their basic package. It's going to be pretty standard across the board. I think we'll see a lot more utilization of those benefits in Medicare Advantage plans. And it'll be good for the plans to attract those consumers because consumers won't be looking at them and saying, this is more expensive, what am I paying for? It'll be a more standard benefit. So we support implementing telehealth in federal health programs. We support the expansion of telehealth benefits, and we support allowing patients to use the method or the method of care delivery that they prefer. So if they're in a rural area and they would prefer to use telehealth to reach a distant provider instead of driving there in person, we prefer that they have that option. So this takes the Medicare program one step closer to fully implementing telehealth, and we are pleased to see that, and we hope that they will continue taking steps to fully implement telehealth in federal health programs.
Next, we want to talk about the 2020 Medicare Advantage Plan and Part D drug pricing rule that came out in November last year. So in this rule, CMS proposed to allow Medicare Advantage plans to require beneficiaries to try on and fail on Part D medications before accessing Part B medications. That's a policy referred to as step therapy. It's intended to control costs, but in some instances, step therapy can be inconsistent with standards of care and can result in delays or denials of medically necessary treatment. While waiting for approval, individuals can have their diseases progress or relapse. So we want to make sure that if they do need a specific medication, that they have a proper exemption or appeals process in place so they can access it. This rule would take effect in 2020. It does implement existing exceptions and appeals processes. However, as I've already mentioned, some of those processes are inefficient, so we do want those processes to be significantly streamlined before this takes effect. Just to talk a little bit more about that burdensome process, there was a study in 2017 that showed that only a small fraction of Medicare Advantage beneficiaries filed a reconsideration for appeal, and of those, only 10% received a decision that was either fully or partially in their favor. So this really shows how it's an uphill battle to file an appeal or exemption and be successful. This rule also proposed changes to 6 protected classes. So Medicare Part D plans are currently required to cover all or substantially all medications in 6 protected classes. CMS has acknowledged that certain vulnerable patient populations may need access to more than 2 treatments, and that's why substantially all these treatments should be covered. And these conditions include cancer, HIV, epilepsy, and mental health, among others. The proposed rule would allow plans to implement prior authorization and against step therapy, whereas neither of these were permitted in the past. Prior authorization is a policy in which a beneficiary must get the payer's approval of a treatment or a service before they can access something that was prescribed to them by their provider. So it's really second-guessing the doctor's medical decision-making. Both step therapy and prior authorization can result in significant delays and denials, symptom severity, as I mentioned, relapse and disease progression, and for very vulnerable patient populations, potentially even death if there is a significant delay. It's particularly harmful for individuals with serious conditions such as cancer and HIV, and some of the others that I mentioned, to the point where ASCO, which is the American Society of Clinical Oncology, has said that step therapy is inappropriate for cancer medications due to individualized nature of cancer treatment and general lack of interchangeable clinical options. According to an Avalier study that essentially undermines this proposal, it showed that plans are already heavily encouraged generics with tier placement and other management tools in place. And that's really the point of this rule, was to encourage people to switch to lower cost medications. Currently, only 35% of drugs in protected classes are generic, and yet generics account for 91% of prescriptions. So as we can see, the tools that are currently in existence are helping to control costs. So there really is no need for step therapy or prior authorization for the 6 protected classes. Additionally, I wanted to point out that in February, Secretary Azar said that HHS may stop insurers from making seniors fail on the same medications more than once, and yet he defended this proposed change to the 6 protected classes. So it is still very important to try and change their minds. And 2 weeks ago, we saw that a bipartisan group of over 70 House lawmakers asked CMS to withdraw this proposal to weaken the 6 protected classes. So even though, again, as I said, the comment period is closed, you can still encourage HHS to do the same. So that concludes the substantive portion of our presentation. We do want to open this time up to questions. And I see, question is, will the slides be shared? And yes, they will. So we have recorded this presentation. We also are happy to share our slides with you in PDF format, and we'll be putting that on our website as well. It doesn't look like there are any other questions at this time. So we do want to thank you for attending. We appreciate you tuning in. If you do have any other questions, please feel free to contact us. Our contact information is on this slide. With that, we'll give you 15 minutes back in your day. Have a good one, everyone.